Hello, everyone. Thanks to the organizers for giving us the opportunity to share our work with you today. So I'm going to be talking about organoid-based models for safety profiling of TCBs. But before I go into the data, let me give you a very brief introduction of cancer immunotherapy. So the human immune system is this sophisticated, highly selective, and highly efficient killing machine. It has evolved over tens of thousands of years to identify and remove threats to our body, whether they are foreign invaders or the body's own mutated cells. And this includes cancer cells. Now, cancer, a master of cellular camouflage, has developed its own ways to evade immune surveillance. And the field of cancer immunotherapy essentially tries to strip away these layers of camouflage to make cancer cells visible and vulnerable to the immune system once again. In short, and in simple terms, cancer immunotherapy aims to develop an effective and durable cure with minimal toxicities, and this is important. Now, cancer immunotherapy comes in many different flavors. You're probably familiar with the most famous modality. This is immune checkpoint inhibitors. So they aim to reinvigorate exhausted T cells, which then rely on their tumor specificity to kill tumor cells. T-cell bispecifics are a fairly new modality, but they're already pretty popular. They're developed by a number of pharma companies, including Roche. They're this special type of antibody that has two arms. One arm binds to any cancer cell that expresses a specific surface antigen. I'll refer to it as the target. The other arm binds any T-cell and activates it via its CD3 receptor. So it's important that for TCBs, unlike immune checkpoint inhibitors, they don't rely on tumor specificity of the T cells. So any cell that is in the vicinity can be recruited. And this concept is known as synthetic immunity. What it all boils down to here is the selection of target. And here is where things get tricky, actually. Cancer antigens, we call them cancer antigens, but they're just overexpressed in tumor cells. They're also found on healthy tissues, albeit at low levels. Let's take, for example, this classical tumor antigen, CEA, or carcinoembryonic antigen. So it's definitely overexpressed in tumor, like in colon cancer here, but you find it pretty abundantly in the healthy colon and to a lower extent also in the small intestine. So Roche is developing a couple of molecules that target CEA. I'm going to talk about two molecules today, a high affinity and low affinity molecule. They're pretty good at targeting cancer. However, because of this intestinal expression, in the clinic we see intestinal toxicities in the form of diarrhea, which in the case of the high-affinity molecule can be pretty severe. And these are known as on-target adverse events, and they're actually a major obstacle for the clinical development of these molecules. Something really important to also highlight is that they were not foreseen by preclinical models. So both animals and traditional in vitro models did not predict these toxicities before the molecules were sent to the clinic. So that means that we need better preclinical models, right, for TCB safety profiling, and this is what we set out to do. At the time we started this work, the emulate intestine chip was the most advanced intestinal model, so we teamed up with them and we entered a fruitful collaboration. I'm not going to belabor the chip because we just had a really nice introduction to it. It's pretty much exactly what we've seen before. We have the epithelial monolayer on top, we have the permeable, semi-permeable membrane, and we have the vascular channel below. Now, before we went into the assay, the first step towards validating the system as a suitable platform was to look at target expression. So we stained for CEA. Oops. So we stained for CEA, and we found that it was indeed expressed and in patterns that match the physiological differences that we see in vivo. So we see high expression in the colon chip and lower expression in the duodenum chip. For the assay, we flow TCB, so the molecules, the CEA TCBs, and immune cells PBMCs through the top channel. And you may be rightfully wondering why the top channel. Well, it boiled down to a technical reason at the time. We essentially, because of the membrane, couldn't get the immune cells to interact with the epithelium. So this is why we went through the luminal route. Despite that, we were able to recapitulate aspects of the clinical toxicity of the TCBs. So in response to TCB treatment, we saw PBMC attachment, T-cell activation, and the release of pro-inflammatory cytokines. The assay was also sensitive to important parameters like concentration, so we see a nice dose response for all of these parameters. And we also saw sensitivity to antibody affinity and potential for clinical toxicity, meaning the high affinity molecule for all of these readouts exerted the high response. And that's consistent because this is also the more toxic molecule. So we think we have a pretty good assay for the prediction and investigation of intestinal toxicities of TCBs, but at the same time it had some limitations. First, we weren't able to recapitulate apoptosis in response to TCB, and this is the primary outcome that's associated with TCB targeting. Second, like with all MPS system, and I think you're all well aware, the throughput was pretty low. So in light of these limitations, quote unquote, we decided to explore conventional 3D organoids as a platform for TCB safety profiling, and this is work done by a talented master's student, Marius Harter, who essentially took patient-derived colon, healthy colon organoids and co-embedded them with immune cells in 3D. This looks pretty simple, and yes, it is pretty simple, it's not rocket science, but it did require some optimization and some troubleshooting. The good thing here is that we have both the TCBs and the immune cells coming from the basal side, so which is different than our model delivery with the organ-on-a-chip system. So before I go into the results, let me introduce a second target and a second molecule. And this is the infamous solitumab. This was a T-cell bispecific developed by Amgen for targeting solid tumors. It recognizes EpCAM, which definitely is overexpressed in tumors. However, we all know that all epithelial tissues are loaded with EpCAM. So you might be wondering why, what were they thinking, essentially, right? Well, I think the clinical strategy hinged on two things. First, the fact that yes, EpCAM is overexpressed and more accessible in tumor cells. Second, again, mice at the preclinical stage didn't show any toxicities. So they went to phase 1, and pretty much every single patient dosed experienced severe diarrhea. So the program was terminated, and it was actually a pretty big disaster. So our question was, if we had the organoids handy at that time, would we have been able to predict these toxicities? So Marius stained for EpCAM and CA in the colon organoids, and he found that they were expressed, and the patterns, again, pretty much matched what we see in the native epithelium. Then he took the co-cultures, and he treated with the CEA targeting TCBs and the EpCAM TCB, and indeed he saw massive and robust induction of apoptosis, as you can see here in the images shown in green and also in the quantification. So this is the quantification is pretty busy, but maybe let's just focus on the 72-hour time point. The different TCBs are shown in different colors. If you just look into one color, you see that we have a nice dose response. Also, the differences in the effects make sense when you take into consideration the different molecules. So we have the strongest response with the EpCAM TCB. As you can see, the red peaks at 48 hours. Apoptosis peaks at 48 hours, then it goes down because organoids are basically destroyed. Then between the two CEA TCBs, we definitely see a higher response with the higher affinity molecule, which also makes sense. So that's pretty nice, but this is just focusing on the epithelial compartment, right? The effects are driven by immune cells. And to get a bit of more of mechanistic understanding of the mechanisms that elicit these effects, we did some in-depth immunophenotyping. This is, again, a lot of data, and I'm not going to go through it. The take-home messages are basically that we have a depletion in the myeloid compartment by the end of the assay, and we have an induction of the T-cell compartment by the end of the assay, which, again, makes sense and is consistent with the mode of action of these molecules. We can also look at some pretty interesting parameters like cytokine release, and via FACS, we can actually trace the different cytokines to different immune cell subsets, which is not the case with the ELISA, with the supernatant-based ELISAs, where kind of everything is dumped together. So when we did that, we find that in both the CD4 and the CD8 compartment, we see this rapid, within 5 hours, induction of TNF-alpha and interferon gamma. So it looks like this is probably enough to establish an inflammatory milieu early on, and then it looks like they drop off, kind of at 48 hours. But this is when the heavy artillery rolls in, and this is granzyme B. this cytolytic enzyme which is responsible for direct on-target killing of epithelial cells. So we see this beautiful correlation between the temporal profile of coenzyme B and the apoptosis that I showed you in the previous slide, suggesting that it's coenzyme B which is actually responsible for the effect. So again, even also in this case, with this readout with the cytokines, we see nice correlation between the effect and the antibody affinity and clinical profile, basically. So we see the strongest effects with the EpCAM TCB in red, followed by the high affinity CA TCB. So we have a pretty robust, sensitive, high throughput, and cheap assay for TCB safety profiling. Well, okay, that's great. However, in my opinion, the results from in vitro safety assays don't mean that much in isolation. They're only meaningful if they're coupled, if they're compared against efficacy effects, right? Well, the good thing here is that we designed the assay such that it captures on-target pharmacology-related toxicities, as opposed to some random non-specific effects. What does that mean? That means that we can essentially replace the healthy organoids with tumor organoids, and we can use the assay for efficacy testing. And that's exactly what we did. So Marius embedded donor-matched, patient-derived organoids and tumoroids with immune cells. You see there's quite a nice difference in morphology. You see the tumor organoids are more multi-layered, and they have this complex architecture. The organoids are more monolayered, and also the organoids are a lot better differentiated. They have higher diversity of intestinal cell types. He again stained for our favorite targets, CA and EpCAM. We find that they're expressed both in the healthy and the tumor organoids. The tumor organoids definitely overexpress them, especially CA. EpCAM seems to be a little bit more subtle, the differences. Then the question is, we saw that we had targeting of healthy organoids. The question is, do we have a therapeutic window? That is, do we have better targeting of tumor organoids compared with the healthy organoids? The answer is, sadly, not really. So this slide is again quite busy and it's just pictures, but it's pretty rich in insights, so I'm going to try to guide you through it. So Marius developed these nice approaches for histological sectioning and multiplex staining of these co-cultures, such that both the organoid compartment and the immune compartments are visualized at the same time. So we have the organoids visualized in purple via cytokeratin staining. Then we have apoptosis in green. And then we have all the major immune subsets also visualized. We have the CD4 and CD8 T cells, we have the B cells, and we have the monocytes. So a couple of things to pay attention to. If you look at the control condition, at 72 hours, nothing really happens. The organoids are happy, they're intact, and the immune cells are just kind of hanging out in the matrix compartment, even after 72 hours. Let's look at the healthy organoids. They're pulverized by 72 hours. There's this high induction of apoptosis, and there's this massive infiltration of immune cells within the organoids, to the point where it seems like all the immune cells from the stromal compartment have translocated into the organoids. What happens in the tumor? Yes, of course, we have some targeting, we have some apoptosis, and it seems like they're also surrounded by these swarms of immune cells. However, at 72 hours, there seems to be this cytokeratin positive core that persists, that outlives the healthy organoids, which is pretty disturbing. And the question is how come? How is it that healthy epithelium is targeted more effectively than tumor epithelium? Well, we don't really know. But if we look at the early time points, we can get a couple of clues. The first reason we think has to do with the architecture. With the organoids, we have this simple monolayer architecture, such that when you poke a few holes early on, it seems like the whole structure collapses catastrophically. And yeah, this is an in vitro model, but it's the same in vivo. It will be a simple monolayer, right? Whereas the tumor organoids, they have this complex multi-layered architecture, and the killing is more sequential. So even if the outer layers of the tumoroid get killed, it seems like the core still lives. It manages to somehow stay alive. Second thing, it looks like immune cells are much more effective in infiltrating the organoids than the tumoroids. Actually, if you look at early on, you see that immune cells intercalate between the epithelial cells within the barrier, which is pretty cool. In the case of the tumoroids, we see immune cells around, but it seems like they have a harder time penetrating the tumor core. It seems that somehow tumoroids are just better at keeping the immune cells at bay for longer. All right, so I'm almost done. Let's translate these observations into a couple of conclusions and implications. First, there's some good news. We find that TCBs are potent molecules that are really good at recruiting immune cells. That means they can make promising and life-saving therapies, right? Bad news. They seem to be at least as effective at targeting healthy cells as they are in tumor cells, which sounds pretty dire, but maybe I'd invite you to look at it from a different perspective. It's a fact that TCBs fail in the clinic because of safety concerns, right? And we finally have a tractable and sensitive system that allows us to recapitulate this clinical reality, however unfavorable, right? So that we can actually use this system to try to dissect the cellular and molecular mechanisms, find the differences that underlie efficacy versus safety effects, and try to leverage them such that you enhance anti-tumor effects but reduce safety risks. So at the end, I just want to leave you with this picture, which I find both visually beautiful and also conceptually fascinating. You see the tumor cells, the tumor organoids here in pink, surrounded by this wreath of CD8 T cells shown in blue, which are themselves surrounded and probably boosted by their helpers, the CD4 T cells. So I just find it pretty cool that we can see the immune system at work in these assays. So this work was done by Marius and our Emulate colleagues, but of course a whole bunch of people contributed. Thanks a lot, and I hope we have time for some questions.